Thank you very much for the opportunity to, as a urologist, participate in this imaging symposium. On April 11, just a few weeks ago, the United States Preventive Service Task Force released a new guidance for PSA testing with a C recommendation for men 55 to 69, meaning individual discussions, and maintained a D against recommendation for men outside of that age group. Let me review with you for a moment the U.S. Preventive Service Task Force past 10-year history in this. In 2008, a recommendation was made against screening for prostate cancer in men 75 years and older. In October of 2011, a draft recommendation was made against PSA testing in any asymptomatic men of any age, and a final recommendation was made in May 2012 with a D recommendation, meaning against any PSA testing. Now, this was reversed partially just a few weeks ago, and let's just look at the prostate cancer data over this time period. Prostate cancer is still the most common cancer in men and the third most common cause of cancer death, as you can see here, based on 2017 data. You see here on the top graph that the mortality due to prostate cancer has decreased sharply. I put a little circle around that, and in fact, the prostate cancer mortality decrease initiating in the 1990s is the biggest decline in mortality of any cancer, outperforming even lung cancer or breast cancer. When you look at the PSA testing, it was introduced in the mid-1980s, and it led to an unprecedented spike in the diagnosis or incidence of prostate cancer. You see this in the top graph. And then in 1994, the FDA cleared PSA testing as a screening test, and that actually was already when the peak of the incidence rate was at its highest. But you can see that these moves, these introductions of PSA, ushered in an area on the bottom graph of decrease in mortality in prostate cancer. And actually, estimates suggest from two independent sources that a good bit of the mortality decrease, 45% from the Fred Hutchinson Cancer Center and even 70% from another group from the University of Michigan, of that decrease in mortality would be due to PSA testing. So PSA is a human kallikrein enzyme, and it is organ-specific, primarily produced by the prostate luminal epithelial cells. It is involved in liquefaction of the semen, the seminal coagulum. And you find very, very high concentrations in the semen fluid, 2 log higher than actually in the serum, which is only that enters into the serum, the peripheral circulation. Prostate cancer cells do not make more PSA than normal prostate tissue. And in the absence of prostate cancer, PSA levels vary greatly by age, race, and prostate volume. In particular, BPH, the benign enlargement of the prostate, can be a big confounder. PSA increases as men age and as the prostate grows, and elevated PSA in prostate cancer is believed at least partially to be a product of disruption of the cellular membranes. Now, there have been screening studies done that led the U.S. Preventive Service Task Force to its conclusion, and the biggest in the United States is the so-called PLCO trial, which involved some almost 80,000 men who were offered PSA testing versus non-testing, and the prostate cancer mortality was the outcome of interest. The first publication in 2009 in the New England Journal of Medicine suggested at the bottom that the death rate was 2.0 in the screening and 1.7 in the control group, and there was not a significant difference. So it was a negative study. Subsequent presentation and publications with extended follow-up up to 15 years verified that, and in fact, the mortality rates never did differ in these two groups. Lately, the authors have admitted that there was a flaw with this study in that the control group had a very high rate of PSA testing called contamination. And they took a stance saying that because of the high rate of testing in the control group, contamination, that the finding really shows that screening in an organized, yearly manner is no different from opportunistic screening whenever the patient comes to the doctor's office. Others take a more dim view, and actually there was a publication just a few months ago suggesting that the control group patient in the PLCO trial actually had more PSA testing than the screen group. So clearly there are flaws with the prostate cancer aspect of the PLCO trial. In Europe, an even larger trial was done, the European Randomized Study of Screening for Prostate Cancer, in which 180,000 men in multiple countries were involved in a similar effort, screening versus control with different intervals, etc., coming to different conclusions. In fact, one of the early publications from 2009, shown here, shows already a survival advantage by 20% in the screen group against the control group. This group, the European group, also did a correction for the contamination, meaning that the control group got PSA testing, and this suggested that the relative risk was 0.49, so a 50% reduction in mortality when controlling for these artifacts, if you will, contamination and non-attendance by the group that was supposed to be screened. And actually, the most recent publications from 2014 and 2016 verify that there is an improved outcome in terms of mortality overall in the ERSCP study at 13 years of follow-up. Now, while these two large studies are almost diametrically opposed, and there might be some reasons for it, more contamination in the US trial than in the European trial, the fact is that it has led the United States Preventive Task Force to recommend first a D and now a guarded C recommendation. There is, and we all recognize it, substantial harm to screening. The harm to screening starts with the fact that the PSA test is often false positive. It then goes on that these men undergo a biopsy. The biopsy may also in itself be false negative. It may, and this is the biggest risk, identify cancers that are not in need of treatment. They are harmless and should actually be followed. In other words, they would best be left uncovered. So this is another substantial risk of systematic screening. The biopsies and subsequent treatments have a significant morbidity for the patient, another one of the slippery slopes of this screening effort. Prostate cancer, once diagnosed, is divided by various criteria and various groups, but overall, all groups agree that there is a low-risk category of patients, mostly those with a Gleason score of 6, that is the severity grading given by the pathologist, and a PSA under 10, let's say, and a moderate volume of cancer. And the overall impression is that these men should not be treated. They should be offered active surveillance as a management strategy. And as a matter of fact, this is not been happening in the United States as much as it should have. Large active surveillance studies done in Canada, in North America, and in Europe demonstrated if patients are properly followed on such a protocol, they are at very low risk. When they come to treatment, their outcomes are similar to patients who are primarily treated, i.e. there is no delayed morbidity, complications, or upstaging. And actually the prostate cancer-specific mortality is very, very low in these active surveillance studies, and the overall mortality is very low as well. This slide, I want you to focus on the left-hand side. This group of men, called CAPRA risk category 0 to 2, would be candidates for active surveillance. And you can see that until the last time period, 2010 to 2013, in the light blue color, active surveillance was underutilized by American urologists. Only recently did American urologists pick up the active surveillance banner and properly offer this to patients at this very low risk category. One could also ask the other question, namely, is prostate cancer always harmless, or is it sometimes in need of treatment? And of course, there are many men who benefit from treatment. There are studies done in Europe and studies done in the United States demonstrating that patients at moderate or higher risk benefit from surgical treatment or radiation treatment. This is a very well-documented study from Sweden, the SBCG4 study, shows on the right-hand side that the patients offered surgery versus active surveillance or watchful waiting had a substantially reduced mortality, and on the left-hand side, an even more substantially reduced risk of metastatic disease. This comes from a European trial. Our institution participated in a trial called PIVOT, the Prostatectomy versus observation trial done in the United States VA system. It also showed a reduced mortality in patients with a PSA over 10 or in patients categorized as a high-risk prostate cancer. So those patients clearly benefited from a therapeutic intervention. There is no doubt about it. And a very interesting trial from the United Kingdom called the PROTECT trial recently was presented very recently, in which men were randomized to surgery, radiotherapy, or active monitoring. And in this trial, it demonstrated that the outcomes with active monitoring were in fact reasonably good. However, you can see an increase in prostate cancer death compared to radiation therapy and surgery, an increase in clinical progression, which is substantial, and an increase in metastasis. So properly choosing patients for active surveillance is the main role of the urologist in this setting. Now, the United States Preventive Services Task Force guidelines in 2012 and before the preliminary in 2008 and 11 had substantial impact on PSA testing in the United States. You can see here one publication in JAMA from 2015 demonstrating a decrease in testing both in 2010 and further on in 2012 when these recommendations were released. Unfortunately, in the opinion of some, and this was published here in 2015, that decrease led to actually reduction in diagnosis of low-risk, intermediate, and high-risk cancer. So the decrease in testing was not focused actually on those men in whom it should have been initiated. And this slide demonstrates that the choice in which patients to do versus not to do screening was not always appropriate. It compares here men with a 50% or greater chance of 9-year survival versus not, and you can see that the changes over time in testing in these age groups does not reflect this particular idea that the elderly patients should be not screened as much or as often. Very recently, just a month ago, in JAMA Oncology, an article was published suggesting that the United States Preventive Services Task Force guidelines have actually led to an increase in metastasis in 2013 compared to earlier years at time of diagnosis, and a reduction in Gleason 6 and an increase in Gleason 7, 8, 9, 10, the higher Gleason scores, raising concern whether or not appropriately screening was done or not done as a response to those guidelines. Now, the current recommendations I will review at the end, and I cannot possibly go through all of them, but I will review with you, first showing you the current United States Preventive Services Task Force guidelines, which I stated is a C recommendation for men 55 to 69, meaning individual discussions are needed. The NCNN guideline recommend actually a fairly aggressive, I would say, screening, and you can see men 45 to 75, and then the PSA is stratified under 1, 1 to 3, and over 3, and the recommendations are made how to go on with that. And this is a very aggressive recommendation starting at 45 and up to 75. The American Cancer Society guidelines, as of now, recommend screening in asymptomatic men who have a 10-year life expectancy, but recommend against that screening in men with a life expectancy under 10 years. Now, it is clear that we need to do better, and we need to simplify this for our patients a little bit. A recent paper that I found suggests that men in 2014 were significantly more likely to have undergone PSA testing without any discussion or proper explanation what the test is, what it would do, and what the consequences might be, than actually in 2012. That's not the direction we want to go in. We actually want to use decision aids for our patients, and that is one of my recommendations, that everybody who engages these men familiarizes themselves as one of those decision aids in their practice that can help men with finding the right way forward to either do or not to do a PSA testing. One of the most important decision aid is also the simplest. That's the Social Security life table. And I'd like to point out that a man 60 years of age has an expected life expectancy of 21 years, and at 70 it is 14.2 years, so it moves up a little bit, and it needs to be taken in consideration when we're talking about a 10-year life expectancy, which is reached at about age 75 currently. The second very important thing is to just look at the patient. This slide stratifies men in the top, the 50th percentile, and the lowest 25th percentile of overall health. And you can see how life expectancy is driven by this overall health. And you can see that a 75-year-old man may have a life expectancy of 15 versus 5 years, depending on his overall performance status. And I would say that these very simple tools, life expectancy and overall health performance, are the most important tools for you to possibly use in your practice. My last slide. I recommend for all of you engaging men in your practice in a discussion on PSA testing to determine that man's life expectancy. Correct it as best as you can based on his overall health status and performance status, and familiarize yourself with one of the many decision aids available that can be printed, given to the patient before the visit. If the PSA in such a man, if he chooses to do that, is under 2.5, I'm with the American Cancer Society. I said it's a green light. Rescreening in perhaps 2-year intervals would be recommended. If the PSA is between 2.5 and 4, and again I'm in favor of the American Cancer Society guidelines, individualize the approach based on age, health, race, family history, perhaps repeat the PSA, or perhaps send the patient to a urologist. If the PSA is over 4, definitely discuss it as a pathological finding. The patient should be sent to the urologist for proper evaluation and decision of biopsies. There are additional tools, many of them. Most of them will not be available to you necessarily. For example, PSA density or PSA Phi score or 4K score. I believe in a general practice setting, they would be mostly confusing. One way forward, Dr. Wofsky talked about, and the next speaker will address for us in urology and in radiology, is improved imaging to improve diagnosis while reducing morbidity by eliminating unnecessary biopsies, is in fact the multiparametric MRI imaging. And I'll leave you with this slide and my personal approach to PSA testing and turn it over to Dr. Costa, who will talk about just that, namely the MRI imaging. Thank you very much.